This is Simplifying AI, a practice guide for revenue cycle management. My name's James Muir. I'm going to be your host for this session, and we're thrilled to have you with us. We're looking forward to an engaging and informative session. Before we get started, let me just go over a couple of housekeeping items just to make sure it's a smooth experience, maybe smooth on our start. Everybody's been muted during the presentation. That's just so we can minimize the background noise. And we are going to have a dedicated Q&A session at the end of the presentation, but we encourage you to use the Q&A. It looks like chat's disabled, but you can use Q&A for your questions. You're welcome to post those at any time. We'll do our best to incorporate your question right into the middle of the presentation if we can. If not, it's okay. We're going to have a little time at the end where we can answer any questions. So be sure to use that Q&A feature anytime you want to. And then this webinar is being recorded. We promised to cut off all the beginning at that you heard the dialogue that we had at the beginning, and it's going to be made available to all of you after the session is over. You're going to get an email with a link to this recording and some special additional resources that we're going to mention in the presentation. But without further ado, let's just dive into the topic. We're excited to be talking about a topic that's probably the hottest topic in many, many years, and that's artificial intelligence. Specifically today, we're going to talk about AI coding, and a lot of noise about that right now when it comes to AI and revenue cycle. And so as I thought, who could we invite that would be the best person to help us sort of cut through all of that noise and confusion? And so I thought, why don't we have Lauren Hall? She's the director out at MediMobile, who does AI coding day in and day out, every day of the week, come and educate us about this. And so I've known Lauren for a lot of years, but for those of you that don't know Lauren the same way that I do, she serves as MediMobile's Director of Account Management, and she's been helping organizations add efficiency to their operations for years and years. She's done tons of implementations with and for some of the largest healthcare organizations in the US. Maybe we'll get lucky and we'll get to hear a few stories before we're done, but she loves to collaborate. She's game for anything that improves the client's efficiency, right, and revenue. She's open to any of that when it comes to collaboration. And so I've gotten to see some of those results that she's produced our clients firsthand. She's from Texas. She's got degrees from Tarleton State and Texas Christian University. So we're in for a treat. Lauren, thank you for being willing to come and educate us on our session today.
James, thank you for having me. I'm excited to talk about AI and everything that UnisLink and MediMobile do as partners to improve workflow and revenue for both large and small customers.
Yeah, that's good. There's a lot of apprehension and noise around AI. So I just maybe I think we've got people on this session that are both in RevCycle and not in RevCycle. And so maybe for the folks that don't deal with RevCycle, what does AI, how does it even matter here? What's the relevance to it? What's the need? Maybe you could speak to that first in a generic.
Sure. So MediMobile has actually been around for over 20 years. And one of the things we pride ourselves on is knowing what the market and what our customers need. And that's where the initiation of creating Genesis came from. So what we did is we looked at what exactly do clinicians need? Well, they need time. And then what do billers and coders need? Just like at UnisLink, they need more time. So that's when our engineering team and development team started the process of building out Genesis. And what we do is we take the documentation, that's the notes created within hospitals, clinics, EMRs, and we feed that through Genesis. And what the process allows for is automatically adding those CPT and diagnosis codes to the encounters. So we're saving clinicians 10 to 20 hours per week. So no longer are clinicians having to go and identify the appropriate CPT or diagnosis codes. We automatically add them to the encounter.
When I talk about AI with folks, I kind of get one of two reactions. I get some folks think it's the holy grail and it will do everything and they don't have to do anything anymore because the robot's going to take care of everything. And so they can let all their staff go. And then I got folks on the other side that are a little bit intimidated by AI and they're, concerned about that. So I don't know, what would you say to those practices that are maybe on the intimidated side of that formula?
So we run into both. We run into people that are super excited about it, turn it on right away, pass through the codes. We don't care. We don't need to see it. We trust it. And then, James, just like you mentioned, we have some people that are very apprehensive. I've literally heard, I do not want a robot coding my charges. So, the really nice thing about MediMobile and our Genesis is the clinicians themselves can approve the codes that we add to the encounters. So they're able to see how we've coded, what we've coded, and we even provide feedback. So there on the screen, there's a scoring grid down below. We use the MDM scorecard used by CMS to code everything. So as long as it's documented within the actual documentation, we'll code for it. And that scoring guideline below is assisting the clinicians in identifying either deficiencies or the areas in their documentation which are adequate. So, going back to the original question, for those that are apprehensive, we do provide the opportunity to approve the codes that we've assigned. So you'll see on that screen the green approved bill button. And of course, if a clinician or a biller or coder disagrees with something we have coded, changes can be made all the way up until it's sent through to the billing system. So that's how we address it. And then, of course, we do have some of the clinicians that absolutely do not want the AI turned on. So it is by profile. So if you're working in an organization that has some clinicians that are very interested and want the AI turned on, we can turn it on for them. Whereas if you do have some clinicians that don't want it, we don't have to turn it on. They can use the standard charge capture. But we always advocate to have it turned on for everybody because you do still have the ability to make edits as needed.
For some specialties, the range of services that they're coding for is pretty narrow and consistent. So at least some of our clients have gotten very nearly 100% accuracy out of the AI coder. So is there a way, if you do trust it, that you don't need to bother with the approval step? Or is there always an approval step in there?
No. So we actually have what's called pass through. And with pass through, what we can do is the clinicians don't even have to log into MediMobile. Once the entire team is comfortable with the coding process, what we can do is we can turn on pass through. And what happens is once we receive the medical documentation, we automatically add the CPT and diagnosis codes to the encounter and we send it straight over to the billers and coders. So there does not have to be clinician interaction. The billers and coders can go ahead and verify the charges out to the billing system. We have some very large groups that their confidence in the AI is there. So we pass along the charges straight into our charge review and they move out to the billing system.
Now, can you make that decision per provider, or does that have to be is it kind of all or nothing when you make that particular decision?
So we can assign it per provider.
Okay, because it would be hard to get several hundred physicians to agree on anything, this particular thing. So, all right, well, that's good. I think we all know that AI needs data in order to work its magic. So, how does, in this case, MediMobile, but how does AI end up getting this data so that it can work its magic on the note and turn that into ICD-10s and CPT codes?
So what we do is we take the feed from the facility, the ADT feed, which is the admit discharge transfer feed. That's going to contain the demographics and insurance information, which are super important for y'all's team, James. And then we take the medical documentation, the medical decision making feed. That's that MDM feed. Those are the notes from the hospital's EMR. So the AI is generated off of the notes that are created within the hospital's EMR. So Genesis reads the documentation the clinician creates within the EMR, and based off of the information found within that document, we will add those CPT diagnosis codes. And then, of course, if the information related to MIPS measures are in the documentation, we can go ahead and automatically add those necessary modifiers. So we're taking it a step further by eliminating those extra questions that some clinicians have to answer due to MIPS.
Yeah, that's a big deal because otherwise you have to report from the EMR if you're a hospital based. And if you're an external entity, you end up missing out on your MIPS bonus.
And just one more thing I want to add, we are launching the PDF upload functionality. So for sometimes we see with rural hospital systems, they're unable to set up a standard HL7 integration. So with the capability that we have with MediCapture, you'll be able to take those PDF documents. They can be dropped in a file drop format, or they can be loaded into the MediMobile system, and we can actually generate the AI off of the documentation that way. So some ambulatory facilities, for example, they don't have the capabilities of setting up those integrations that standard facilities do. But we now have an alternative to address that situation, which there's a lot of times you'll see with like post-acute facilities or clinicians that see patients in facilities that just don't have that integration capability. We're accommodating that as well now with the AI.
So just to recap here, so there's two integrations essentially, right? There's the one that brings us the patients, and then there's the one that brings us the notes. Did I hear you right?
That's correct.
Okay, so I know this is not AI related, but I'm just thinking about this. So when we get the patient integration working, does that act like a rounding list then for the provider? So they, when they go into the facility, they know who they're going to see based on looking at that list. Is that how that? Tell me how that works.
So, yes, we can populate off of the ADT feed, that admit discharge transfer feed, and that would allow the creation of a rounding list. Now, it is important to note that the clinician for that particular rounding list must be listed as the admitting, attending, or consulting clinician in that feed for that patient to automatically populate to that clinician's list. But yes, we have several groups that use MediMobile for a rounding list. I will tell you the population off of the documentation feed, what we see with that is the increase in accuracy and that increase in revenue because we ensure that all billable document types are accounted for. And again, the AI runs off of the medical documentation feed, but you do have both options.
Okay. I assume that they can search for a patient anywhere. If it turns out they're not listed, that, in the perfect world, everything's listed correctly, but in an unperfect world, maybe the patient we're about to see, it wasn't listed. You can just look them up.
Absolutely. We have a very easy search feature that clinicians are able to use. And the really nice thing, because I know anybody that's in a revenue cycle management knows this, when you have duplicate patients. So, what we have with our search feature is the ability to identify any previously created patients. So, that helps ensure that the clinicians aren't creating more versions of a patient.
Okay. Shelly's got a pretty good question here. I'll see if I can summarize this. Once they've received the notes, how long does it take the AI to actually read the note and then do the coding for it? And then I'm going to extend her question just a little bit. Hopefully she won't mind. What if the note is woefully inadequate? Will the AI break? Will it not be able to code it? What will the physician's experience be in that scenario? So kind of two questions there.
So we typically, depending upon the facility, we receive the documentation in real time and we're able to add those CPT and diagnosis codes almost instantly. In just a few seconds, the clinician will not only see the encounter populate to their active list, but they will also see the CPT and diagnosis codes automatically added to it. So it's just seconds from when that documentation is signed. Now, if a clinician is not documenting, let's say, clearly, or there's just no detail, we will still populate the encounter to the clinician's list, and the clinician would be able to add the CPT and diagnosis codes. We do have folder options that make that selection a lot easier. And this is the platform that some of our customers are still on, where they add their CPT and diagnosis codes, or we can pre-populate them based off of previously completed encounters. So as long as we receive something for that patient, we will populate that patient to the clinician's list. But if the documentation is inadequate, two things can happen. Like I said, the CPT and diagnosis codes can be manually entered by the clinician, or in the event that we have detected the probability of adding a particular diagnosis code, which I can show you here shortly, we will indicate that there's not enough information within the documentation to support it, showing the clinician that they need to go ahead and make a revision to the document.
Okay, so in that scenario, would they do that in MediMobile, or they would go back to the original system that they're using to document their note in, and then it just feeds back? What's the loop look like?
So we do have the ability to set up a bidirectional feed with the EMRs, but Our suggestion would be for the clinician to go ahead and go back into the EMR and make the necessary adjustment in the note, and we will receive that note back in real time and we'll go ahead and recode it. And that way, your documentation will match the CPT and diagnosis codes going into the billing system, again, to reduce those denials.
Okay. Hopefully that answers your question, Catherine. If that doesn't, go ahead and augment. But I think if they update the note, it just automatically comes back, it sounds like. And then
Yes, that's correct.
And of course, in the default setting is they look at the note, they look at the way that AI has coded it, and they approve it or they don't approve it, right?
Yes.
Okay. Well, so let me ask you one more question. Then I have an idea. We're gonna pivot just a little bit. So, from a provider's perspective, what are they most likely to notice on a day-to-day basis compared to how they're probably doing it right?
So they will notice a significant decrease in the amount of time they're having to spend utilizing charge capture as a whole. They're not having to go and research the appropriate CPT or diagnosis code anymore. They can simply log in to MediMobile, click approve, 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 and go about their day. So the time savings for the clinicians, that's the first thing that we hear about. But then we start to hear about how the turnaround time to be reimbursed is significantly decreased as well. And then the number of denials goes down because we do use those CMS guidelines and we can account for nuances for organizations. So if a particular organization wants to track something, we can add specific codes. So the organization they're able to track it. But we see a huge time savings and then, of course, an increase in revenue, which couples with that decrease in denials. So, for example, one of our really large hospital systems, they increased their revenue by $3 million in 1 month. And that's coupled with the AI and the ability to account for all billable document types.
Okay. Do you find undercoding happens quite a bit?
Yes.
Or the more missed services types of things?
The majority is the missed services because MediMobile, we saw that is how we started populating off of that medical documentation feed, the notes feed. So that's where that started from, was because we noticed so many services were not being billed at all. But going into the undercoding, for example, critical care, typically when the clinicians are coding for themselves, they typically undercode, which we know is loss of revenue. So with the AI, what we're able to do is we're able to take a look at the notes and provide the appropriate coding to ensure that things are not being undercoded and money is not left on the table.
Okay. I'm going to ask you more questions about results here in a minute, but I'm going to pivot here. I think we've got time, and I know you weren't expecting this. Do you mind? I mean, you guys are just doing the screen share right now. Is there any chance we can see the app? I mean,
Absolutely.
have it there to share. I mean, I think these folks would love to see it. We've got a lot of folks on.
Certainly.
I appreciate you being flexible.
Okay. Is everybody able to see my screen?
I can see it.
Okay. So this is MediMobile's active list. And you'll see right here that we have 5 encounters that have not yet been completed. That's this red circle. And then we have the 22 incomplete from previous days, which allows the clinicians to go back. And if they were unable to complete their billing from the previous days, they're able to do so. So I'm just going to click right here on our circle. And you'll see here, I'm actually going to start with Sophia Davis's encounter. I'm so sorry. Give me just 1 second here.
Maybe it's not agreeing with our Zoom webinar.
Maybe not. Let's see. Let me reload. Okay. So what we will do, and let me stop and then start one more time. Sorry about that.
Is that, are you logging in as essentially the same way a physician would log in? And is that experience different on their phone versus on a PC?
So yes, I am using the web. We have both a web and a mobile app. So the clinicians can use either. I do really feel that our mobile app does mirror the web app pretty significantly. We'll see. I'll point out just a couple of differences, but if you're able to use the web or the mobile, you can transition pretty easily. Just kind of depends on your preference.
Okay.
So I'm going to go. So you can see right here, and this would be one of the instances I actually just mentioned, where there's just not enough detail within the documentation to to justify the diagnosis code. There was just enough information to indicate that it probably should be there. But this red triangle with the exclamation point indicates to the clinician that anaphylactic shock was indicated in the documentation, but there is not enough detail to support it, so it would likely be denied. So this is that trigger that I believe Catherine brought up, where the clinician could go back into the hospital's EMR, add the additional details, and as long as nothing has been approved in MediMobile, we'll recode this encounter, and then that bill could be approved. So you can see here, and I'll even pop out the documentation over to the side. So this is the actual note that was created within the hospital's EMR. So the clinician's able to come over and see the note if they would like. So what we can see here is that the CPT codes have been added, and then our diagnosis codes have been added as well. So again, that red is indicating to the clinician there's just not enough detail within the note to support this. So the clinician can go into the hospital's EMR, make that update. We can reabsorb the note and recode it. Or the clinician may decide, I actually don't believe that I should have that in there. So again, if they want to update that note, they can, or they can simply hit remove. Now, these with the orange, our system has detected that there could be an increase in specificity. So again, the clinician can go into the EMR and add those specific details, but we also have the ability right here to use our refinement tool. So when you hit that word change, it provides you with additional specificity for the particular diagnosis code. So I can just click here and you'll see that that orange went to green, indicating it's valid. I will tell you, with anything unspecified, the bill can still be approved. It's only those that were deemed invalid that have to be somehow altered or removed before you can click approve. James, do you have any questions, or do the viewers have any questions?
I don't see any questions yet, but I do have a comment.
Yeah.
Getting that higher level of specificity will make a really big deal for you guys when you have contracts that are full risk and using HCCs in order to determine your reimbursement and what's called your RAF score. So if you're participating in an ACO, or most of your managed Medicaids and Medicares all use HCCs. So that prompt for the higher specificity is a really big deal. It increases your RAF score depending on the size of your organization. Just improving your RAF score by a percentage can mean it can mean hundreds of thousands of dollars in many cases. So it increases the pool. So that's a very cool. I don't remember seeing that before.
Yeah. And the really nice thing about this refinement tool, and James, like we talked about, some clinicians, they feel more comfortable coding their own charges. So this refinement tool, if a diagnosis code is added that does allow for more specificity, the refinement tool would still be available in the manually coded version of MediMobile as well. But it is very, very helpful when we're making those suggestions here in AI.
Okay, wonderful. I noticed you couldn't approve it until you had the red one resolved.
That is true. So it will not allow approval if an invalid code is added without specificity. So again, our goal is not only to increase revenue, but decrease denials. And so when there's just simply not enough information based off of CMS guidelines to push a claim out, that's when we will add that. We'll add the diagnosis code in the red to show the doctor that additional detail needs to be provided to support.
Okay, and don't let me throw you off your groove here, but what about the service level or the CPTs, like the services that we're doing?
So we will automatically add those CPTs. You can see them right up here. Those can also be removed or modified. We do have two added from the note to the right, but those can be modified just like the diagnosis codes. Again, those CPT codes are a lot more straightforward as we go through the notes. The diagnosis codes are the ones that typically need the changes.
Okay, and I see some kind of a scoring rubric down at the bottom.
Yes. So our goal, while we work with the customers with the AI, we will provide feedback to the customers based off of the documentation we're seeing. We know that clinicians are very busy and sometimes they have to rush to complete those notes. So what we always try to do is provide the feedback to the team of what we're seeing with the documentation. So this right here is a scoring guideline. Again, it's used with CMS, but what we are looking to indicate to the clinicians is the detail and the the items that were addressed within the documentation and provide some feedback. When we're working with the organizations, we do provide detailed feedback to the designated parties at the organization to get back to the clinicians. But fortunately, it is rare that many changes have to be made. We have a lot of great clinicians that document very well, but in the event that there is some work that needs to be done, we can provide that, which actually takes me to a really cool story that we have about the AI. So we worked with a large cardiothoracic surgery group, and anybody that's on the call, whether it's revenue cycle or clinicians, y'all know that WinVacs have two different codes. And the difference between those codes is a 50-centimeter piece of tape. So clinicians notoriously do not document that 50-centimeter piece of tape. It's just not done. So coders have to comb through the documentation, sometimes having to reach out to the clinicians. And of course, they become familiar with the clinicians' patterns. So what we were able to do in the interim is we asked the clinicians just to put a greater than 50 sign in the document somewhere, and our AI could pick it up and we could code it for that particular wound code. So that was in the interim. In the meantime, our system was evaluating the patterns of verbiage used by the clinicians that used that particular code. And by the end of it, we were able to automatically code appropriately and accurately, but we do have those interim solutions. So the AI, as we all know, it's very, very smart, but when something is just simply not there, we can't code for it. So we can make accommodations while our system is learning.
Okay, we've got a couple of good questions here, and you can continue if you want to. One question is how the AI is learning. And I was going to ask you that when I started talking about implementation later, but maybe I'll hit you with three questions. First of all, how long does it take to learn? And then second, is it learning across individual providers? Is it trying to aggregate its learning across all the providers? Let's just start with those two, and then I got some more follow-up questions.
So we typically say 90 days to learn documentation. Sometimes it's a lot faster. The documentation is very clear, concise. We can go ahead and confidently turn it on ahead of the 90 days, but we tell all our customers 90 days, and our system starts learning the documentation the day we start receiving it. So as soon as we have that feed set up, Genesis will start learning the documentation and processing the CPT and diagnosis codes out. The really nice thing is clinicians can utilize MediMobile as is. So right here, this is MediMobile without the AI turned on, and they are able to enter their CPT and diagnosis codes. We do have favorites most used in my list. We can create customized code lists for the clinicians. But while Genesis learns the documentation, we will also bounce it against the coding that's done by both the clinicians as well as the billers and coders. And if we see any discrepancies with how we are initially coding, we'll reach out to the organization just to see if there's a difference, maybe something the billers and coders or the clinicians know that we don't, just like the 50-centimeter piece of tape. That is actually how we discovered that is the AI was coding early on. And we were looking at the data that the coders were entering for the encounters, and we noticed that discrepancy. So we reached out and we said, hey, where are y'all getting that? Because it is absolutely not in the documentation. And we found that it was actually the clinicians verbally telling. So we are learning from day one, from the day that MediMobile is provided the feed or when the codes are flowing into the billing system.
Are there scenarios where it takes the AI longer to learn? Well, let's say complex or maybe an unusual procedure that isn't, maybe they've never done it before and this was the first time. What will the AI do when it sees something it's never seen before?
So I haven't seen that happen. Our AI thankfully is very smart, but similar to the question that Catherine answered, if there's just not enough detail or if it's something the AI has not encountered before that cannot be added, again, our goal is to make sure all revenue is captured. So what we would do is exactly what you see on the screen here. The encounter would populate without the AI. So you would have an encounter very similar to Ava Miller. And so the patient would populate to the clinician's list. and then the clinician would be able to add the CPT and diagnosis codes manually. But in the background, anytime that happens, we have a team and a system that is evaluating anything that couldn't be coded. And then if we have questions, we can, of course, reach out to the organization. Or let's say you have a new clinician that starts working for your facility and their documentation is we're going to say not codable by the AI, we can reach out and notify you of those patterns.
Okay, now I'm going to extend Shelley's question just a little bit. What happens in 2026 when we have a new set of coding guidelines? How is that handled? Are you doing something on your side to make sure that we're now using the 2026 guidelines as opposed to the 2025 guidelines? How does all that work?
Absolutely. So we're always going to account for date of service, and we do this in standard MediMobile. So clinicians, if they are back billing, we are going to allow those codes to flow through based off of the date of service. But the day that those codes are retired, we will no longer allow them to be entered for that specified date of service. We can put a hard stop that says this cannot be billed, or we can allow the ability to change the code. In terms of the AI, it works just like it does in MediMobile with our coding. The codes from the previous year would be retired, and then our AI is updated automatically with that initiated data service.
Okay, great. Hopefully that answers your question, Shelley. If not, go ahead and hit us with another question and we'll try to incorporate it. Is there something else you wanted to show in the application? Because I've got quite a list of other questions I want to hit you up with, but I want to make sure we show everything there is that you want to show.
Yeah, just real quickly, like I said, if the clinician does not want the AI turned on because it is based off of profile, we will again add every encounter we receive to make sure that everything is filled out. It would look like this, where the clinicians are able to select the CPT and diagnosis code. Again, we have these customizable folders that make billing so much easier. And then with the AI, we have one that we don't have any invalid codes. We have two valid, indicating that there is enough detail within the documentation to support that coding. And we have two unspecified. Again, if the clinician wants to leave the diagnosis codes unspecified, they can, and they'll just hit approve bill and that will be sent over. Another really nice feature that we can include with the AI are any questions. And this is for tracking that can populate once the clinician approves the bill. So for instance, on this particular demonstration, we have the avoidable day reason selected below. So this particular customer does want to track the avoidable days. They can just select that and then hit next. And you'll see that that bill went from incomplete to complete. We now have one complete bill. And if you look at the widget to the left, you'll see that instead of a full red circle, you have some red and some green, indicating that you do have that one encounter that has been completed.
So the goal is to get them all green by the end of the day.
Yes.
Okay. All right. Is there anything else in here you want to show? I've got a couple of other follow-up questions here.
Just going back to the search, let me just show you how easy it is to search. So I just clicked on this green person right there. I'm just going to enter the word test and I'm going to hit search. And so if for some reason a patient does not populate to the clinician's list, they can very easily search. They'll just highlight that patient and add that patient to their list. Now, this is really nice. If you're in an instance where a facility doesn't have a feed and you need to actually add that patient to more than one date of service, you can easily do so by clicking on those days. And you just hit add patient and you'll see now that my patient list has gone from 5 to 6 and I now have that test patient added to my list.
Okay. Would that be also the same thing if I show up, a patient that I didn't expect to see is now a patient that I need to see, and all I'm getting is a face sheet or something like that? How is that scenario handled? Would we do it the same way? I'm going to add the patient myself?
Yes, if the patient does not populate to the clinician's list automatically, they can absolutely use the search feature, that green person button up there. But if we do receive an ADT message for that patient, it would automatically populate.
Okay. If I end up with a face sheet or something like that, or I'm using charge capture only, is there a way to capture that face sheet into MediMobile?
Absolutely. So I do prefer the mobile app for capturing the face sheets. I think it's super easy. You just snap a quick picture, but you can also do so on the web. You can just come over here to this patient information tab. and you'll click view face sheet, and then you can easily upload your face sheet from your computer. Again, I think the mobile app's a bit easier. You have the exact same functionality to upload your face sheet, but you just snap a picture. It does not save it to your phone because we know we don't want to walk around with face sheets on our phone, but it goes straight into the patient information. And from there, that patient would be loaded onto the clinician's list.
Okay. Now we've got a lot of questions here. So I think maybe some folks didn't make the very beginning when we talked about the
Okay.
integration. So when you did the search for the patient, where is that information coming from?
So it's actually coming from the hospital's feed. So the patient search does come from that admit discharge transfer feed, the ADT feed. Those are going to be the patient demographics and insurance.
Okay. And then a related question is, what if this is a practice and can it be used in an ambulatory practice environment? Does it make sense? And in that case, does it come from the practice management system? How does that work?
So we do integrate with some practice management systems. We integrate with ECW, Athena, Care Tracker, Tibra, all the different systems you can imagine. But in an instance, and we actually were working with a group of ambulatory facilities that do not have the capability to set up an HL7 interface. Those are the standard interfaces for that ADT and MDM. So if you have a situation where an interface cannot be set up by the facility, we can actually set up a file drop, or the face sheets and documentation can be manually loaded into MediMobile, and we can go ahead and process those and automatically add the patients to the clinician's list that way. So if you're working in a facility, or you have clinicians that work in facilities that do not have the capability to set up a standard HL7 interface, we do have an alternative, and that's that PDF processing. We call it MediCapture. So I say a PDF, it doesn't have to be a PDF, it can be a picture, but our system will read it, add it to the clinician's list, and even do the AI coding if the information is available.
All right, that's fantastic. We got a lot of folks on here. So could you just quickly mention some of the inpatient systems that you've got integrations with, and maybe even what the types of systems we might see in the skilled nursing environment?
Yes. So we have integrations with Cerner, Meditech, Epic, just to name a few. We've worked with rural health systems that, like I said, they didn't have the capability to set up their HL7 interfaces. So our integrations team, we have a dedicated integrations team, which sets us apart from other charge capture solutions. But our integrations team was able to work with those facilities to help them set up a first time integration. We're actually in the process of working with one of the largest hospital systems in the country to set up the very first interface that they will have with the charge capture solution. So, like I said, we talked about the different billing systems we integrate with, but also we integrate with all EMRs. We have yet to encounter an EMR that we cannot integrate with, but in the event that does occur, like I said, we are able to process the documentation, whether it be a picture, a PDF, and those can be file dropped to us.
Okay, outstanding. All right, well, let me transition a little bit. So we talked kind of what the physician or the provider's experience is like. So once they have accepted or completed the charge and sent it on, what's the experience like for the coders and the billers?
So for the billers and coders, what we see, and let me see, I may have to shift to, yes, let me shift over to a different demonstration account. So for the billers and coders,
So if you want to, Lauren, it's okay.
so they are actually able to save up to 75% of their time. So when we talk about even that pass through where the clinicians aren't touching the CPT or diagnosis codes, the AI is coding it for them. No longer do those billers or coders have to go back through and comb through the documentation. It's done for them. Like I talked about that group with the 50 centimeter piece of tape for the wound vac. Those coders were having to comb through that documentation to try to figure out, okay, do we add it? Do we not add it? That same group had an instance where they were doing trial procedures. They not only had to go to the EMR to review the documentation in the EMR, they also had to go into their system to review the insurance because they needed the claim and approval number to indicate it was a trial. Whereas with the AI, we were able to detect the different items within the documentation to go ahead and add that trial code. So the coders no longer had to dig through those individual documents and different systems. The really nice thing for any team that's working in the background is the documentation is physically in MediMobile. So if a team does need to further review a document, it's right there in MediMobile. You're not having to toggle between the screens. And with the AI, what passes through to the billers and coders that are reviewing what has taken place, they see it exactly like the clinician would have seen it. They do have the opportunity to add those refinement options if needed, and then, of course, approve the coding to go out to the billing system.
Okay. Awesome. All right. Well, so one of probably the top question that I get when I talk to folks about any kind of coding AI is they want to know how good it is. So, like, what's the accuracy that we should expect? Maybe not. You don't have to answer for every AI coder in the world, but for MediMobile specifically, what kind of accuracy should we expect from the AI coder?
We are very, very proud of our 95% accuracy. And the way that we've gotten there is our development team that works with the AI, they are constantly looking for the deficiencies. And that's how we've gotten to that high rate. They want to look at any discrepancies that they see in the coding ahead of the AI being pushed out for the customers, and we address those. So, of course, our biggest line of business is that inpatient work, but with our specialties, we have radiology, cardiology, neurology, things like that. We maintain that 95% accuracy rate.
Nice. And I noticed for a couple of our clients, we got a revenue bump because we're the rev cycle side of it, right? So just getting everything better actually improved things for us. So you mentioned it a little bit earlier, but maybe you could go into some more detail about what kind of results you typically see when you're implementing this at a healthcare organization. You can pick whatever. I think probably best to speak to whatever you typically see. But you mentioned a 3 million in a month. That's absolutely incredible. I'm not sure I know which hospital that is. I know that has several hundred physicians. So, but if you could just speak to that, so people could like, what's the payoff for implementing something like this?
With medium-sized practices, we see the turnaround about 3 months. They start to see that revenue increase, their denials decrease. And that's, it's a team effort. Our implementation team works with the organization, but within 3 months, they start to see that increase in revenue. And part of that increase in revenue is also the decrease in denials, because we know when there are denials, it takes a significantly longer amount of time to recoup that revenue. So the decrease in denials added to identifying any missed revenue. Those billable document types are key. I can't tell you how many clinicians and organizations we have that are missing out on revenue. It's just left on the table because they don't realize that it could be billed for. So our team works very closely with the organization to identify anything that's billable that can go out of the billing system for claims. Now, that large hospital system that we did talk about earlier, they started working with just the billable document types, ensuring that everything was being captured with those billable document types. They saw a $3 million increase in 1 month. And that's not a hospital system as a whole. That is just a group of hospitals in a large city here in Texas. And it's a very well known hospital system, but it was just a subset of their facilities that saw that jump, just being able to account for those billable services that they were not previously accounting for.
Yeah, that's fantastic. What about the time side? I think you mentioned earlier that it saves time for the physicians. Do you have any, like, what expectations should we be setting to providers about the time saving side of it?
So again, like you mentioned earlier, some clinicians use just a small group of codes, so they're able to go into MediMobile pretty quickly and manually code everything. But then we also have clinicians that they're having to research what CPT and diagnosis codes have to be entered. And in that account, it's anywhere from 10 to 20 hours per week. With those clinicians that are very comfortable with coding, they use the same codes all the time. It's going to save them that process of having to manually enter them. So it's a little bit shorter for them, but definitely for those clinicians that are looking up the CPT and diagnosis codes themselves, we see a decrease of 10 to 20 hours per week. And for the billers and coders, they're saving about 75% of the time on their job that was previously spent reading through documentation. So they're able to focus on maybe more complex cases or other tasks that maybe have been ignored because of the amount of time it takes to code.
Yeah, that's huge. All right, well, let's talk about implementing this. So, done tons of implementations. I know that. What's involved in getting this set up, right? What
Mhm.
are the things that are going to happen?
So Once that contract comes through, whether it's through a great partner a great partner like UnisLink, or it is coming through straight to MediMobile, as soon as we receive the initial setup information, it takes about 30 days to build everything out. In tandem with the build, we will reach out to the facilities where the clinicians see patients to set up those feeds, the ADT and the MDM feeds. The MDM feed is necessary for the AI. It all depends on the timeline for the facilities. So like I said, we have a dedicated integrations team ready to set up integrations the second that conversation gets started, but facilities sometimes have other projects. So that timeline becomes dependent on the facilities. We have a gauge based off of the facilities we previously worked with, so we can give you a rough estimate of how long we've seen it take in the past. But the goal is always to have everything set up and moving within those 30 days. Again, if you're using the AI, we talked about the 90-day wait time, but the customers can absolutely begin to use MediMobile using the ADT and MDM documentation. So the patients can populate to the clinician's list, they can add the CPT and diagnosis codes while the AI is learning. So it's not 90 days until they can use MediMobile. But in the meantime, our implementation team works with the customer, or in the event that you are partnered with Unis, we work with UnisLink. So the organization themselves doesn't have to take out any time for setup. We have a great process set with UnisLink. It's very seamless. So we work with their team to get everything set up for you.
Is there a bunch of tech that has to be set up? I mean, is this going to add any headache for providers? Is it pretty straightforward? Do they just use their own phone or their PC at the hospital, or what?
Yeah, no, it's they can go to medimobile.com and log in on any computer. Of course, we do work with organizations that use SSO or certain security measures to log in that go through their individual facility portals. We can absolutely set that up as well, but clinicians can very easily access MediMobile on the web or download the MediMobile app on their phone.
Okay, so they got a browser, they're good to go.
Good to go.
All right, what about, where does training fit in? Does this take a lot of training? Is it short and easy? What's involved on that side?
So we offer virtual training with a human on the other end to all of our customers. So that training usually takes about 30 minutes. And we also have PDF documentation that can be provided, as well as videos that can be loaded to the clinician's accounts.
Sounds pretty straightforward. Well, we're kind of, I actually thought we would end up a little early, but yeah, we used that time on the demo, so that's good. We got a couple minutes left, and I do have a couple of questions, but maybe before we address the sort of the random questions, is there anything you would add for the audience on AI coding with MediMobile that we haven't talked about already?
So we just celebrated our 2-year anniversary of Genesis. It was about 2 years ago that it was launched, and we had our very first customers sign up and use it. They're still going strong. Their revenue has increased significantly. We were able to catch things that they were not catching before. So definitely check us out. We always want to highlight our partnership with UnisLink as well. They're a great company to work with. Like I said, it makes the transition to utilize MediMobile seamless, because the UnisLink team does all the administrative items that we need for setup. But here at MediMobile, just like the screen says, we're more than just charge capture. We are constantly evolving based off of what we're seeing the clinicians need, as well as the billers, coders, and executives within organizations. So another really nice thing that I say we would put up against anybody in any industry is our support team. We have 24/7 support for our customers. Call in, email, anything. We have that 24/7 support. So definitely, if you would like an individualized demo of MediMobile, go ahead, scan that QR code and sign up for a demo. And then, as always, if you're already working with UnisLink or have plans to, we will work with them to get you the information you need about MediMobile.
Yeah, if any of you are our clients, we're happy to set up a demonstration for you so you can see it's very simple to set up. So most of the questions as I look through here through the random ones, I think we've already addressed. I've got a big group apparently in Rhode Island, so they're just wanting to know more about how the onboarding works, but I think you've already kind of touched on that. And then we've got the opposite. I got a smaller group that doesn't have a full-time IT staff. So how in a scenario like that would we be helping them with the integrations so that they could put something like MediMobile in place?
So, like I said, we've previously worked with some rural hospital systems that they just didn't have a team that had ever set up an HL7 interface. So, again, we have a couple of options. Our team is happy to help work through that process if it's never been done before. But we also can, the face sheets and the documentation can be scanned and loaded into MediMobile or using a file drop and we can populate it that way. So we have a couple of different options to accommodate smaller IT departments or departments that just haven't had experience in setting up integrations. We're here to help. We're here to help customers be successful. One thing, UnisLink and MediMobile has in common is it can be a one clinician group or it can be an enterprise hospital system or a physician management company with thousands of clinicians. We like to treat everyone as the important customer, and that goes for implementation down to support. So if you're just a one clinician group but you want AI, go ahead. We will not limit it to anybody.
Well, that kind of leads into, I got two last questions here. The one is a larger group that is saying they have over 500 providers and they're just wondering how high can it scale? So you just mentioned thousands. Is there an upper limit that you're aware of from a scalability perspective? Or it doesn't seem to be a limit.
No, there's not a limit. Again, because when you talk about that many clinicians, our AI, we use those CMS guidelines, the MDM scorecard. And typically there may be one or two pieces of documentation that we have to refer back to the organization, say, hey, we need more detail here, or instances where maybe something isn't being sent to us, but we go directly to the organization to figure out the root cause and make those adjustments where needed. But there is no cap.
Okay. And actually, perfect last question. How can we get a hold of you to ask more questions? Is that just using the QR code, or is there another way that you'd like folks to reach out to you?
You can absolutely use the QR code. You can go to medimobile.com and schedule a demo. Or, like James said, if you're a current UnisLink customer, they know exactly how to get a hold of us.
All right. Hey, thank you, man. I know I get you with a lot of stuff that you weren't expecting today, but I really appreciate you sharing your knowledge with us. Um, and very grateful to have you with us and helping our clients on this. So thanks for coming. I appreciate it.
Well, thank you for having us, James. We welcome the opportunity.
All right. Well, for everyone who still remains, we'll send you a link to the recording of this session along with some additional information. And so if you have questions, you can reply to that email as well. Thank you for joining us today, and we will see you on the next one, which is going to be about denial management. And I think that's this next Wednesday. So again, thank you, Lauren, for being with us. We appreciate it.
Thank you, James. Everybody have a wonderful day.